Hello and welcome to the Revital Vision training presentation on patient selection, clinical protocols, and treatment process. My name is Shlomo Abramson. I'm a certified optometrist and the clinical service manager at Revital Vision. We've divided the treatment process into two phases. Phase 1, the setup. Identify a suitable patient, tell them about the program, and bill them. Then, the patient needs to be set up on the management portal with their personal information and exam data. Phase 2, the training. After setup, the patient will receive an automatic welcome email with their login information and training instructions and can begin home training. Halfway through the program, the patient will return to the clinic for a quick follow-up exam and once more at the end of the training program. Throughout the training, Revital Vision provides remote support and monitoring for the patient. Now, how to identify a potential candidate for the program? Revital Vision is suitable for three types of patients. The first, patients who can see well with glasses. This includes patients with amblyopia and other pathologies like nystagmus, retinal, and corneal diseases. The second, patients with low contrast sensitivity function. They're patients who are complaining of poor vision quality, like poor night vision. Note that low contrast sensitivity can also exist in emmetropic patients with good visual acuity. The programs are post-Lasik and post-cataract. And the third, the glasses haters. These are patients with a minor refractive error on the verge for the need for glasses who are not interested in wearing the correction. The programs are presbyopia for near, low myopia for distance, and post-LASIK patients with a residual refractive error post-surgery or experiencing regression. So who is suitable for the program? Patients who are motivated to improve and willing to train. Ages 9 and up, patients with stable vision, patients with access to the compatible technical requirements needed. Non-suitable patients are patients with unstable vision. In the Amblyopia program, patients with 8 prism diopters tropia are excluded due to the risk of triggering suppressed diplopia. Patients with epilepsy and patients with severe migraines or severe attention disorders should try the demo program first to make sure that they can handle the visual tasks. Now the amblyopia criteria. The criteria for the amblyopia program are as follows. Ages 9 and up, best corrected visual acuity as low as 2100 for monocular amblyopia and up to 2200 for binocular amblyopia. Eye deviation should not exceed 8 prism diopters. The patient can tolerate the full optical correction in the amblyopic eye. Please use an appropriate visual acuity chart that has all the Snellen lines between 2200 and 2100 for patients with VA that's lower than 2100 to ensure that you can appropriately measure the VA improvement results, as seen on the left here with the Logmar VA chart. The protocol for the amblyopia treatment is as follows. Make sure the cover test and best corrected visual acuity fit the criteria. Prescribe the full correction and let the patient get used to the correction prior to the training. If anisometropia is higher than 3.5 diopters, prescribe contact lenses or Shaw lenses to overcome the anisoconic effect. Training is done while the dominant eye is blurred by a semi-transparent white cover, as pictured. The training is recommended for 40 sessions with a follow-up exam at the mid and end points. Follow up on best corrected visual acuity, binocular vision, and contrast sensitivity function. You can stop the patient training once they reached a plateau and completed their 40 recommended sessions. The low vision criteria. This is usually a binocular program, so best corrected visual acuity can be as low as 2200. The vision must be stable without daily fluctuations. It can be any pathology that causes central vision loss. We recommend that these patients with low vision try a demo trial to verify that they could handle the visual task. It's recommended to train at least 40 sessions. Some patients respond slower than others or continue to improve later on, and they may require 60 sessions or so, or even more, until they reach a plateau. Follow up on best corrected visual acuity and contrast sensitivity function near and distance. Also, follow up on stereo and binocular vision in patients with binocular dysfunctions like nystagmus. The low myopia and post-Lasik programs are similar in their criteria and protocol. Patients who have a minor refractive error, where two plus lines of improvement in uncorrected distance vision will be significant for them. Post-Lasik patients with low contrast sensitivity function complain of vision quality or side effects. Note that they can be emmetropic with good visual acuity. It's important to manage expectations, as patients who don't use glasses usually feel subjective improvement, but patients who have been using glasses regularly may be disappointed as they will be able to see better with their correction. The goal of the program is to improve uncorrected vision, so the patient will train without correction, or with training glasses if the program instructs it. The company will deliver the training glasses to the patient. The training is done binocularly unless there's a big difference in visual acuity between the eyes, like more than 3 lines. In that case, the patient will train one eye at a time. It's recommended to train at least 30 sessions with a follow-up exam after 15. Follow up on uncorrected visual acuity and contrast sensitivity function. Now the Presbyopia program. The goal of the program is to improve uncorrected near vision, which can delay the need for reading glasses by about 4 to 5 years. Patients should have up to a 150 addition and uncorrected near visual acuity between Jaeger 1 and Jaeger 4. Patients with near visual acuity worse than Jaeger 4 will also improve near vision, but 2 lines of improvement will probably not be enough to read small text without reading glasses. It's essential to manage expectations with the patients, as this is not a permanent solution, but a temporary one, as presbyopia progresses throughout the years. The patient will train without correction or with training glasses if the program instructs it. The training is done binocularly unless there's a big difference in visual acuity between the eyes, more than 3 lines. In that case, the patient will train one eye at a time. It's recommended to train at least 30 sessions with a follow-up exam after 15. Follow up on uncorrected visual acuity for near and contrast sensitivity function if available. The post-cataract program is for patients who are unhappy with their vision quality after surgery. It may be due to low contrast sensitivity, difficulty to neuroadapt, or side effects such as halos and glares or a residual refractive error. They may have good visual acuity, but low contrast sensitivity function, or they may have both low visual acuity and low contrast sensitivity function. The goal of the program is to improve their habitual vision, so the patients will train with or without their correction. It's recommended to train at least 30 sessions with a follow-up exam after 15. Follow up on visual acuity and, very important, contrast sensitivity function. The sports vision program is for people with 20/20 vision who would like to optimize their vision performance and improve their acuity and contrast beyond 20/20. The average improvement here is about 1 line on a visual acuity chart and 50% improvement in contrast sensitivity function. The program is suitable for athletes, specialty jobs, military, and more. The patients train for 30 sessions with their habitual vision, and we follow up on visual acuity for distance and near and contrast sensitivity function. The important guidelines for training. Patients train 3 to 4 training sessions a week for a total of 30 till 60 sessions depending on the program. Patients train in a dark room, train 1.5 meters or 5 feet away from the screen, unless instructed otherwise. Very low vision patients can move closer. And monovision patients who would like to improve their blended vision will train at a mid-distance of 2.5 feet. Monocular training, like we mentioned, blur the dominant eye. Patients can take a single long break between 7 to 10 days during the whole training period if needed, not more than that. The follow-up exams support the patient's compliance and will also show you the clinical outcome. That concludes the presentation. Thank you for listening.